Good evening and welcome to our DEI task force, NYACP. This is a webinar co-sponsored by the NYACP DEI task force and the well-being committee as session 7 of the Wisdom and Well-being series, making healthcare work better for physicians and patients. So the genesis of this conversation started when the DEI task force was debating on what to do with various important topics around the country, especially around equity and inclusion. One of the things that came very clear was the fact that New York State in December of 2020, passed a law called Racism as a Public Health Crisis. We thought that was a very important law that was passed at the time, but we never understood what it meant, what the commitment of the state of New York was to health disparities and health equity along the lines of the law. So we reached out to the Department of Health, inviting the commissioner or designee to join us in our first DEI task force webinar to address that topic. And here we are today. We are very lucky to have Ms. Johan Moon. She's the Deputy Commissioner of Health of the New York State Office of Health Equity and Human Rights. So that is the genesis of this webinar. Now, just a few things. I'm going to be introducing her. She would speak for about 45 minutes. Following that, we would have 10 minutes of questions or so. I'm going to encourage everyone to put your questions in the chat box. I'll be reviewing all the questions, and then she'll be responding to the questions as they come along. If there are no questions in the chat box, I have my own questions lined up. I'll be happy to moderate and then pick up with the questions and answer sessions at that time. All right, so now let's go to the introductions. So Ms. Johan E. Moon is the Deputy Commissioner, Office of Health Equity and Human Rights for the New York State Department of Health. She was appointed in August of 2022 as a member of the department's cabinet to lead the department's health equity and human rights planning, policy development, and programming. The office is made up of AIDS Institute and the offices of Minority Health and Health Disparities Prevention, Gun Violence Prevention, and Diversity, Equity, and Inclusion. So it's a huge office at the DOH. Prior to her recent appointment, Ms. Moon worked with the AIDS Institute for 15 years, serving as the director for 6 years. The AI portfolio includes HIV and other sexually transmitted infections, prevention and care, viral hepatitis prevention and treatment, drug user health and wellness, and LGBTQ+ health and human services. Ms. Moon's leadership has advanced the state's ending the HIV epidemic and hepatitis C elimination initiatives. Her leadership led to the department's implementing essential policy and changes to promote expanded access to HIV, sexually transmitted infections, and hepatitis C prevention, treatment, and care, as well as federal statewide harm reduction programming and LGBTQ+ service delivery. Ms. Moon's early career included leadership positions in public health, domestic violence, substance abuse, organizational development, and organizational change management. Ms. Moon served as a board member of the National Alliance of State and Territorial AIDS Directors, serving as a board chair from 2019 to 2020, on the executive committee from 2018 to 2022. In 2019, Ms. Moon was appointed to the CDC HRSA Advisory Committee. That's a very important advisory committee on HIV, viral hepatitis, and STD prevention and treatment. The advisory committee advises the health secretary, the CDC director, and the HRSA administrator on objectives, strategies, policies, and priorities for HIV, viral hepatitis, and STD prevention and treatment efforts. Throughout the COVID-19 response, Ms. Moon was an essential member of the COVID-19 response leadership team. Throughout the COVID-19 response, she also led multidisciplinary teams and statewide initiatives, including antibody sampling, community-based pop-up testing and vaccination, statewide mass vaccination sites, and also participated on the New York State Executive Vaccine Equity Task Force. Most recently, Ms. Moon has continued to participate in the state's response to emerging public health issues such as polio and the like. The foundation and framework of Ms. Moon's work prioritizes equity, social justice, and trauma-informed care. Her best advice is only a brief 2 words: be nice. So that is Ms. Moon. Today, she's going to be addressing this very important topic, addressing health equity. How is New York State taking action? Please welcome Ms. Moon.
All right. Well, good evening, everyone. First, let me thank you for taking the time this next hour to join tonight's WebEx, if you will. I recognize how busy everyone is. So that's my first point of thanks. My second point of thanks is really for all of the work that you do to maintain and improve the health of New Yorkers, particularly as we reflect on the last 2 to 3 years, given our emerging crises, multiple public health crises. So thank you very much for the opportunity to join you this evening, and certainly thank you for taking the time to read that exceptionally long bio, which at the end of the day really just speaks to the fact that I'm very passionate about public health and the opportunity to work in an office that prioritizes health equity and looks at the opportunity to advance and to make sure that people's human rights are leveraged and are present for them is an honor that I can't even put into words. So let me start by saying, I'm sure like all of you, we always work best in a team. I'm joined this evening by my colleague, Casey Griffin. Casey is a member of the team. She is a fellow with the Public Health Corps, which is a very large New York State initiative that offers the opportunity to gain public health experience hands-on. And Casey's joined this evening to help me with the PowerPoint and all the things that I can't do at the same time. Multitasking used to be a thing for me. It no longer is at this point in my life. So, Casey, why don't we bring up the slides? All right, so our first point of success, good. All right, so again, the Office of Health Equity and Human Rights. And when the question is asked as far as what is the commitment of New York State in moving forward and looking at the advancement of health equity and a response to the persistent and consistent disparities that I know all of you are seeing within your practices. One of those responses is with the development of this office under the leadership of our most recently past commissioner, Dr. Mary Bassett. If you're not familiar with Dr. Bassett, I would so encourage you to look up her bio, look at the work that she has done on a global level as it relates to the advancement of health equity. Within New York State, Dr. Bassett served as a New York City Department of Health and Mental Hygiene Commissioner for some years and was our commissioner here at State Department of Health for the past year. And her vision and her prioritization of health equity as being the core of everything that this department does as we move forward certainly has allowed us the opportunity not only to build an office that can help centralize and provide support to our department as well as to our communities across the state, but at the same time, speak to our responsibility to ensure that individuals have access to the care and the health and life satisfaction that they deserve. Next slide. So this is an incredibly busy slide, and I fell in love with this. I did a presentation some months ago with a partner from the Equity office within the governor's office. And myself and my colleague, there was an artist who was able to develop and create this visual as we were speaking. And so as we were speaking, she picked up on some of the key terms, and I want to point to the areas that have the boxes around them, because it's just a little highlight of what I intend to touch on this evening. Looking at the opportunity for changing or advancing policy and practice in public health. In order for us to be able to continue to advance, we have to be able to be responsive to the emerging issues. Certainly yourselves within your own practices, as you continue to see individuals who come in, recognizing that each individual has a unique set of circumstances as far as their ability to engage in prevention, as far as their ability to engage in treatment, and then as far as their ability to sustain whatever gains that they have made in their individual health. Within that, of course, are the many barriers and challenges that people report. And when we talk about equity, and we talk about the work that we're looking at prioritizing across New York State, it certainly speaks to the many determinants of health that individuals have as barriers due to the absence of sufficient support systems, the absence of perhaps housing, food access, transportation, managing, the responsibility of their family, income, poverty. And we could continue it, I'm sure you could, based on conversations that you've had. And then, of course, we have the ongoing issues as it relates to the fact that we are an aging society. And we recognize that the impact of aging has certainly brought to light, and most recently, the department also prioritizing the look at aging across all policies, has developed an office to look at long-term care and aging so that we can continue to advance and meet the needs of individuals who are presenting with comorbidities and co-occurring disorders. So the ability to change policy and practice. Next, exploring justice, equity, diversity, and inclusion across New York State Department of Health, and recognizing that we have to do our own work within the walls of this department in order for us to be able to accurately and effectively look to advance policy and programming across the state. And so for that reason, part of what this office is responsible for is the workforce training and looking at our opportunities to diversify the workforce, not only within the department, but across the state. And so initiatives such as the Public Health Corps are opportunities to bring in students who may not otherwise know how they can gain specific and intentional hands-on experience. And then the last box that I circled is the conversation of looking at equality versus equity. I find that when we're in these conversations as it relates to diversity, equity, inclusion, we tend to use a lot of the words interchangeably, but within these words are concepts, and those concepts are very unique and different from one another, as evidenced through your patient's experiences. Next slide. So just briefly to talk about the Office of Health Equity and Human Rights, this is an office that has been made up of existing offices within the Department of Health, as well as new offices that will help to continue to advance and move us forward. So the AIDS Institute, which was described earlier in the bio, the Office of Minority Health and Health Disparities Prevention, Gun Violence Prevention, and a new office looking at specifically workforce development around diversity, equity, and inclusion. We will be continuing to add initiatives to our existing office as we move forward, and I'll talk about one specific area related to health equity assessment within hospital settings. Next slide. So in an effort to offer two examples of one of the areas that we work in within public health and within this office is if we were to look at disparities in gun violence. What we know about gun violence certainly is that it is currently the leading cause of premature death in the United States. From both a healthcare as well as societal costs, we're looking at hundreds of billions of dollars. And the disparities that are being experienced represent themselves in the number of homicides, specifically looking at both national, state, and city data, in which the majority of individuals are non-white, so individuals from Black and Hispanic communities. When we look at, I'm just going to move this here, okay. When we look at also the number of Black and Hispanic individuals who are 10 times and 3.4 times as likely to be killed with a gun as compared to white individuals. So the level of disparities that are happening within communities of color, particularly in Black and Hispanic communities, is absolutely one of the areas that we are focused on. And I want to underscore the point, and we'll talk about this in a later slide, in that, a lot of the work that we do from a public health lens as to how we are attempting to intervene and reverse these trends is by working with community. And so most of the achievements that we have made have been because of community stakeholders who, number one, have lived experience and can tell us what their needs are, as opposed to us making assumptions. And number two, who have power within community through the development of trust in a way that we as government officials or even as community providers at times do not. Now, I'm making that point because I recognize that within your practices, there is also a comparison that can be made. And what I want to make the point about when we look at how can we create a practice in an environment that, number one, is non-stigmatizing, is welcoming, and allows people to be the expert of their lives, is by regarding the patients that you see as just that, an expert. And I'll talk in a few moments about harm reduction and about the power of harm reduction that we've utilized in a public health setting as we address racial equality. Next slide. Okay, I'm going to move that there. So another example, looking at HIV and AIDS, what we know is that 39% of individuals who are newly diagnosed fall between the ages of 25 to 34. 49% of individuals who are newly diagnosed report a history of male-to-male sexual contact. 78% of newly diagnosed individuals identify as male, cisgender, and Black, non-Hispanic, and Hispanic individuals account for 75% of persons newly diagnosed with HIV. Now, as you heard in my bio, I am a very strong advocate of the work that we've been doing across the state to end the epidemic. And from 2015 to where we are today, we have made significant strides in heading in the right direction with significant decreases in HIV diagnosis. And it's very easy when I go out to speak to talk about all of our achievements and the fact that we have seen a reduction in HIV diagnosis in every demographic group. But if I only gave you that point, then in fact I would be misleading you. Because at the end of the day, regardless of the fact that we have had successes in overall reduction, what we still have is a disproportionate impact to Black and Hispanic individuals who continue to be diagnosed at a rate, as indicated in the bottom right reference, accounting for 75% of individuals newly diagnosed. So what that speaks to is that we have a lot more work to do. And when we first moved out with ending the epidemic as a community discussion, again, at the vision and the advocacy of community stakeholders, we made a commitment that we would leave no community behind. So while we can point to the data and the analysis that shows that we have made many strides and in fact have achieved one of the key definitions of what ending the epidemic means, we can't say that our job is done because we have communities of individuals who are still disproportionately impacted, primarily due to the determinants of health that they do not have ready access or consistent access to. Next slide. And then of course, COVID-19. So as we looked at the years of the pandemic and the work that was done and looking at the data, we knew, right? And one of the things that I often say is I was really taken aback during COVID, especially in the early days when people were saying things like, well, COVID showed that there are disparities because we were seeing more individuals of color, particularly Black and Hispanic individuals, who were being hospitalized and who were dying. And what struck me was that for some people, it seemed as if this was a novel idea, when in fact, of course we were going to see that in COVID. And of course we're going to see that in ongoing public health priorities, because this is a persistent issue across all health outcomes. The disparities that exist have not been responded to in a way that we have any type of sustainable change. And so there is a lot of work that we have to do when we talk about the achievement of equity. And when we talk about looking at the disparities that communities are living with. COVID, in my opinion, is another example of the fact that while we have made advancements in medicine, and while we have made advancements perhaps in our ability to speak openly and honestly about the disparities that we're witnessing, and about the causes of those disparities, including structural and individual racism, we have not created a sustainable impact that allows individuals to not face these disparities in every public health crisis that we see. Next slide. So, I wanted to take the liberty of having this conversation in that when I speak, I often speak of communities. I speak of larger groups. I speak of the policies and things that are broad in nature. But at the end of the day, one of the things that is significant to the work that we do is our own selves as individuals. And the fact that we have opportunities in the environments within which we work and within which we live to impact change. You yourself as physicians and working within physician areas, healthcare areas, have an amazingly dynamic opportunity to impact change. And so what this slide does is speak to the cycle of structural oppression, of our own individual implicit bias, and as a result, the poor health outcomes that individuals often experience. The cycle has to do with the fact that when we don't address in meaningful ways the dominant cultural narratives that feed our implicit biases, then in fact what we're doing is we're helping to strengthen the cycle and allow it to continue to advance forward. Within our practices, we have to take the time, and I mean that from the point of entry of practice to the point of exit, to ensure that the team and the staff that we're working with have the space in which they can have their own discussions, to talk about the feelings that they have, to talk about what they don't understand, and to address implicit bias. If you looked to the first slide that I showed where the individual had created that visual for us, part of what we talked about was that, oftentimes I'll get on an elevator and we'll have had a training here at the department related to implicit bias, related to racism, related to oppression. And the word that most often is said to me after being greeted and being told that they attended the training is the word awkward. And I know that people just pray for the elevator door to open, because when they tell me that the experience for them was awkward, I tell them that that's a good sign, because it's not about wanting people to feel awkward in a negative way, but it is about wanting to create a space where people can feel awkward in a purposeful way and can recognize and question what is it about the discussion that has them feeling uncomfortable. The ability to impart education, awareness, and expectation within our workforces is key for us to break these cycles. And one may think, how much of a difference or an impact can one individual make? But if you think about all the individuals you see in a day, and recognizing that your patient is one individual, is often surrounded by family, whether present in your actual appointments or not, that impact stretches to all of those individuals. So I have a confidence that while challenging and while persistent, we can break through these cycles, and we can create an intervention in which we can change how we view and interact with people, how we set expectation of culture within the practices in which we offer care, and how we can change the history moving forward of what coming to care looks like in an environment that is welcoming, that is supportive, that is non-judgmental, and that allows for people to be whom they are. Now, I want to make the point that in a lot of the discussions around equity, many of us start from a place of race. And the conversation as it relates to racism is a long-standing conversation, and we cannot deny the impact of race as a factor to some of the challenges and the outcomes that we're seeing. That said, I think it's really important when we talk about health equity that we recognize that individuals who present before us are more than only their race. And so this applies to thinking about the whole person, how someone identifies as far as their sexual orientation, an individual's gender identity. Yes, of course, an individual's race and ethnicity. Knowing the cultural norms of an individual has a huge impact on what it is you might assess and what it is you might prescribe. And in order to do that, we have to get comfortable in asking the questions. We have to be comfortable in creating the spaces where we take the answers and we promote education throughout the practice. When you look at the disparities, particularly among individuals who are transgender, and you hear the stories and you see the antidotes as far as some of the experiences that people have had we only taken the time to ask a question, we may have been able to create an encounter for that individual that would encourage them to come back and utilize care and prevention services. Next slide. So achieving diversity, equity, inclusion, as well as health equity. And if you look to the left, a lot of what is represented here is really the conversation that I spoke on earlier, in that, you know, we have to work within the walls in order for us to have impact outside of the walls. And that means the impact that we want to see across community as it relates to care, as it relates to health outcomes, and overall as it relates to the satisfaction of life. In order to do that, we have to, and I know I say this, but I keep saying it because part of my goal in this office is to ensure that what we create here is sustainable change. And what I mean by that is sustainable change that can have long-lasting impact on our communities, that can improve health outcomes, and that can sustain regardless of who sits in what seat. And so with that, certainly it speaks to our need to develop a culture and an expectation. The slide to the right is one that I'm sure many of you are familiar with, but it's often the confusion, and again, it's about the fact that words do matter. So many of us may have the experience where we go out and we say, well, everyone has access to the fruit on the tree. And that's probably true. Everyone has access to the fruit on that tree. But can everyone reach that fruit? And I think a lot of times that the detail of actually being able to reach that fruit is where we get lost, because we don't ask the question. How many times have we provided a prescription to an individual or a recommendation of an over-the-counter drug, but do we ask the next question? Can you purchase that? Do you have access to that pharmacy? Particularly when you talk about individuals, you know, in rural areas. Asking someone to leave your office or leave your location and go to a store to purchase an item could very well be a 2-hour trip. So asking the question as far as, yes, I know you see the fruit, but can you reach the fruit, is a huge part of building equity. Next slide. So health equity initiatives, legislative actions through January of 2021, looking at different states, you know, obviously with the ongoing, what do I want to say? With the tragedies that we continue to see, not only in New York State, but across our nation, as it relates to violence, as it relates to death, as it relates to the many tragedies that we have seen come upon Black and Hispanic individuals. The conversation of racism has opened up in a way that, at least for me in my lifetime, I have not seen. The ability to have very frank, open, purposeful, and transparent conversation is one that we are taking very seriously now, as it relates to the opportunity of political will, as it relates to the opportunity of policy change, and as it relates to the opportunity to, yes, sound the alarm that racism is a public health crisis and in fact is an emergency. The declaration that has been made in New York State is one that has been made in other states as well. And I think it's a very fair question to say, well, what does that mean exactly beyond an alarming statement? And in my opinion, in New York State, what we see when we say that racism is a public health crisis is that we have just made it a responsibility of everyone who has influence within a public health system, within a healthcare system, and with a support service system to recognize that we have to take part and actively engage in education, awareness, and accountability, so that when individuals are receiving care or support, racism is not the contributing factor to why they do not return or why, in fact, we fail. And that is seen through policy change, that is seen through resource allocation, that is seen through our ability to engage with community stakeholders in developing plans as we move forward to impact change. Educational inequities. So legislation has looked to address educational inequities, certainly as we look at our school systems and the disparities that we see between schools based on their zip code location. Data collection and use, provider education and training, infrastructure, and the history and impact of racism. If the history of racism is only speaking to slavery, then a true, full, comprehensive review of racism is not being provided. And in our professional and in our personal lives, we have to start asking the question of why. So when legislation goes through, when policy change is made, that's one step. Again, it's about that accountability, and it's about us looking at our own practices in which we have influence to determine how we will advance these opportunities moving forward. So again, here you have an example in which a number of states, and this isn't a full list certainly, but an example of states that have moved forward in looking at how can we take tangible steps to reverse this historical offense. Next slide. Leadership dedicated to equity in all policies. So here you have examples of different state agencies in which we have continued to advance. Looking at the Office of Addiction Services and Support, the opportunity of advancing harm reduction services within their treatment settings, the opportunity of looking at treating the whole person. Going back to my comment before, that at times we tend to focus on a part of a person, and particularly in healthcare, given the challenges I know, and I know there's a lot of pressure every time someone walks into a room and you're working with them. But also recognizing that when that person walks in, they may be speaking about a specific pain or a specific area of concern that they have, but with that is a whole person in front of you, in addition to whatever the presenting concern may be. And I don't want to suggest that I have the answers of how to make your practices in a manner that can be efficient and at the same time be wholly responsive to every person that comes to you. But what I do want to point out is that the opportunity of addressing the whole person may in fact have greater and longer standing outcomes if the opportunity can present itself to have a practice that is multidisciplinary. The justice, equity, diversity, and inclusion, again, looking at the work that OASIS, or Office of Addiction Services and Support, continues to move forward in thinking about how we work with individuals who are so often marginalized in our communities, that being individuals who use drugs. The State Department of Health, of course, and we'll show you some of the other governor level advancements as it relates to policy, and then looking at our environment as a place of holding responsibility around equity. For me, myself, my background as read is really around public health in the sense of looking at substance use, looking at domestic violence, looking at HIV and prevention. And so I'm coming into this seat learning a lot as it relates to economy, as it relates to climate, as it relates to other areas of our environment, the access to green space, the access to bridges so that people can get from one place or to another, and the placement of where we provide care so that people aren't traveling whole days in order to have appointments that usually turn into more appointments. All of these are areas that we can focus on. All of these are areas that have an impact as it relates to actual equity. Again, I asked a question. I know you can see the fruit and it's there, but can you reach it? Next slide. So these are some of the examples of how our administration here in New York State has moved forward in making equity a priority with the announcement of an equity agenda, $4 million to increase mental health workforce diversity. Certainly, if you had the opportunity to watch the State of the State yesterday, the announcement about the prioritization around mental health and looking at those opportunities to create an increase in the number of safe spaces and space beds for individuals who need interventions as far as their mental health concerns. The advancements of the LGBTQ equity as part of our most recent budget, and looking at, again, funding allocations so that we can provide more support for individuals in the community. And certainly, I'm sure you're all aware, the continued advancement around equity as it relates to cannabis in New York State. And then lastly, a new Office of Language Access, recognizing that across the entire state, not only in New York City, the availability of language access to individuals in a way in which it actually is not a disruptor, but a bridge, is something that is absolutely essential to remove, to have, as far as able to remove a language barrier for people who are seeking to access care. Next slide. So this slide may be a little bit self-serving. I am a huge fan as it relates to trauma-informed care. And the reason for that, certainly, if not before, but coming out of COVID, is that one of the number one things we hear from individuals is just this feeling about the consequences and the impact of having experienced trauma. And so looking at the opportunities to really engage and integrate trauma-informed care into the areas in which we provide care to individuals is key. When I talk about integration of trauma-informed care practices, it's not only around the benefit of the individuals who are being served, but it's the benefit of the workforce as well. And so, looking at having trauma-informed offices, the trainings that are available, looking at evaluation to see the impact that having a trauma-informed culture within your practices, it is something that I think would be quite a learning lesson for all of us. What we find is that throughout our lifetimes, all of us experience trauma in one form or another. And having an environment that really sort of addresses that, accepts that, and acknowledges that has proven to be very effective. We have had a pilot in place for the last 3 years working with a provider from New York City who has trained staff and trained trainers within care or healthcare facilities around trauma-informed care. And the feedback that we have received as far as the ability to maintain a supportive and engaging environment, the reduction in the number of negative interactions that are experienced between individuals being served and those who are working in these facilities, and the sense of support and satisfaction that individuals report really show the evidence of trauma-informed care as an intervention in practices. Next slide. So guiding principles to address disparities, and these are the areas in which we are going to prioritize as we continue to move forward. Reinvesting in our neighborhoods, certainly when we think about neighborhoods across New York State, and again, recognizing that we as a state are very diverse as far as the communities in which people live, between urban, suburban, and rural. And the needs in each of those areas are certainly different and nuanced. But reinvesting in our neighborhoods, giving power back to community members. You may note that I often speak of community stakeholders because what we have found is that having people with lived experience at all of the tables in which we make decisions, particularly as it relates to policy and practice, is truly what has allowed us to be successful. And if I would use ending the epidemic as an example, I think that's one of the greatest opportunities that we've had when we talk about reinvesting in our communities and giving power back to the individuals who are working with us to help develop areas of care and areas of support. Again, speaking to community voice and power, making sure that there are individuals representative of the communities that we are trying to impact, and creating spaces for communities to be able to meet and to have voice and to plan. addressing those social determinants of health, which I understand many times when we talk about social determinants of health, it can seem overwhelming. The needs that people are presenting with are overwhelming, particularly in the last 3 years. But in my opinion, if we're going to do and create and advance sustainable change, addressing these social determinants of health are the only way that we can impact change, because when you think back historically on why people are able to succeed or not, it always points to the barriers of what individuals were missing. If I don't have a bed to sleep on at night, I'm not coming to my appointment tomorrow. If I don't have access to support my active drug use, I'm not coming to the appointment I scheduled with you tomorrow. So we as a society have a lot of work to do in thinking about how we can create systems of transitional care for individuals. We have some great examples if we were to look across the globe. What we have to do is be willing to accept that perhaps that the change and the policy change I speak to is one that's essential. And we have to make a committed effort, not only within New York State, but across this nation, around the resources that are needed in order to meet the demands and the needs of people. Employing individuals in the workforce, and again, creating practices in which individuals will walk in and will see people who look like them, who speak like them, who understand perhaps the immediate community that you're serving, so that it doesn't feel like a foreign experience every time I walk through the door. Community-driven investment, which speaks to my points related to increasing access to social determinants of health, and certainly looking at opportunities in which we can invest in youth. Again, during the State of the State yesterday conversation or declaration that was made as it relates to looking at mental health services and the increase of mental health services for young people, and creating spaces for young people where they too have the opportunities to speak, to provide input, and to build their own, in some ways, community resources and support. Next slide.
Just a caution on the time, we have 10 minutes.
Yes. So just to briefly to look at this slide, thinking of innovation as far as how we change the future of health and some of the commitments. I've talked a bit about individuals who use drugs, and certainly we know, I know all of you in your practices are certainly having the experience of individuals who are impacted by the opioid epidemic. New York State is not unique in this. This is across our nation, and the greater opportunities for people to be harmed it is so real, especially with the presence of fentanyl in our drug supply. So responding to the overdose crisis in New York State, using a public health approach, using a harm reduction approach, accepting people where they are at, and working with people in incremental steps. I use this as an example as far as why I think harm reduction is a great form of building equity, and that it creates a space in which individuals have voice in what their next steps will be. And we respect those choices, even though they may not be exactly where we think they should be on that particular day and that particular time. But what we need to do is continue to expand and enhance our harm reduction practices so that we can continue to engage with individuals and protect them. Next slide. Laws impacting patient care. So I use this example as one specific policy that is new. This is legislation that was signed in 2022 that we are putting into place now. It comes into effect in June of 2023. The health equity impact assessment requires that any Article 28 facility who's submitting a certificate of need due to some impactful change that's being made, such as construction, has to do an equity impact assessment. And the intention here is to make sure that as decisions are made on changes within practice, that there is knowledge of the community and by the community, that patient voices are centered in how the impact of the change is going to result in change, and making sure that people in the community are informed. So there will be more information that's moving forward and going public as it relates to the health equity impact assessment. But at the end of the day, the goal here is to ensure that the needs of the community are being heard and being responded to. Next slide. And I won't spend a lot of time here. Again, I've talked a lot about community engagement and allyship. And regardless of what type of practice you work in, I really want to encourage you to think about the people that come in as your patients, as members of the community, who really can give voice to how we can impact and move forward related to health equity. Recognizing racism as a public health crisis is one that requires a response from all individuals involved, both those who are providing care and those who are receiving care. Next slide. Okay, so my timing there worked.
Perfect.
And I want to say thank you. You know, I don't want to suggest that anything that I've touched on tonight is not something that yourself, your colleagues, your practices have not already considered. What I do know is that it is very challenging to impact change. And so these conversations are really, if you will, at times a reminder that not only do we have a responsibility to impact change, but if we truly want to serve people and impact communities to achieve and advance in clear goals that will improve health, then we have to be the voices that move this forward. So I thank you.
Very nice. Thank you very much for this wonderful talk. In the interest of time, I'm just going to go straight to the questions. There are 2 questions in the chat box, so you can all take a look. The first one is from Shane Solga. The question has to do with language access and whether there are any laws around language justice. In other words, for the example he gave was, we have a lot of patients, for instance, in Brooklyn, that are Creole speaking, and there's really nothing around, standardized, discharge planning, documentation for these groups and other groups as well. So, do we have any laws addressing that or in process?
So, I think it's a really important question, because at the end of the day, if we're discharging individuals without the ability to be able to read and be able to move forward with what is being advised on discharge, then we're doing a disservice. I don't want to speak to any one particular provider. I certainly don't know all the nuances of the circumstance. But what I would like to say is that if this is a facility that is saying that there's a barrier or some type of inability to provide summaries in the proper language that a patient is able to speak in and to read in, then we should talk and we should figure out what that barrier is so that we can see if we can resolve that. We're not doing anyone any favors, and that's not sustainable.
The next question has to do with the workforce diversity. The question came from Richard Torres. The question is, how can we ensure workforce diversity when we lack people of color who are mental health providers? How do we actually solve that problem without having enough people providing?
Yeah. So this is a huge problem, right? And this is a national problem, not only in New York State. Providers, whether we're talking about physicians, whether we're talking about mental health, substance use, across the board, we have to take some very intentional steps to continue to build our workforce, to diversify our workforce, and especially to diversify the language of our workforce so that patients can be seen and spoken to in the language that they speak. I recognize we have a lot of different language access tools that we utilize, including us here at State. However, I want to say, as someone who, in my lifetime has received a diagnosis, right? I couldn't imagine if I received that diagnosis by phone and was speaking through someone else to speak to my physician, who is supposed to be the one that's going to get me to a place of better health. So, I know we do what we have to do based on the tools and the resources we have, but I also want to suggest that we can continue to do better. So what are the things that we do? Well, I think some of the things that we've seen in New York State, for example, when we talk about tuition reimbursement, we talk about free tuition going to SUNY schools and CUNY schools, creating opportunities for individuals who may not have the resources to enter into a field of their choice of study, but clearing that path so that people can get into these programs. And also offering, incentives to individuals to want to stay within programs. When I worked in a teaching hospital at one point in my life, what I found is that many of the students were returning to their home countries, which that in itself is gratifying. At the same time, there were many of these students who could have had tremendous effect and impact here within the US. And so, I wonder what it is that we can do to encourage people to, number one, want to enter into fields, particularly in public health, and then number two, want to continue to work in these fields. I also feel that, in doing this work, and I'm not a physician, so I should have said that up front, but we also have to create space for people that have influence. And I think sometimes it can be that the policies and the decision making happen separate from those individuals who are actually doing the work on the floor. And we have to change those pathways and create larger pathways for people to have input into their practices and into how they know the people they serve need to be cared for.
Yes, I just wanted to add to that conversation. As an example, the AAMC, that is the body that's overseeing the colleges of medicine across the country. The matriculation rate for new students into medical schools is about 7% for Blacks across the country, right? Whereas, in the normal studies, you see that it's a lot of, problems around what we're talking about. So that has been a big, big problem in terms of medical education. In other words, we cannot possibly get to the number we need of Black and Hispanic, and I think Hispanic or Latino population about maybe 5%. So the two together make up 12% of the entire medical school, right? So there is no way to get enough numbers to actually solve the problem. So a lot of schools are doing different things. At Downstate, we are doing different things. We have a College of Medicine. We did different things. Last year, the percent of underrepresented in medicine in the first year went up from 9% to 30%. So it's possible.
Yes.
It went up. We were able to recruit 30% of the class, the first year class, are underrepresented in medicine. So these are not impossible conversations. It's just that people have to think through, look at what is possible on the ground, what is possible to tweak, and then just fix it, and then things can move forward. If all colleges in the United States have 30%, matriculation rate for underrepresented medicine students, this issue would not be a big problem. There are other things that people can do. For instance, the NIH has many, many programs encouraging, STEM programs and also pipeline programs for students to get into the health professions. At Downstate, we have a number. I'm actually the director of the Health Disparities Center at Downstate. We have millions of dollars to do just that, educate the high school student and the undergrad students and the grad students and junior faculty across all fields to gain some interest in the health professions, any health profession. That also is part of the solution. But again, this is locked up in universities, and it doesn't really account for the majority of the problem around the country. We have one more question here. It has to do with reinvesting in our neighborhoods and increasing access to mental health in the neighborhoods. How do we do that from the state perspective?
Sure. And let me say, just to your last response, I absolutely agree with you. All of this is possible, but what we have to be is intentional. And the other point that I want to make that I think a lot of times people find challenging is we also have to do it in partnership. And so that sort of lends to this question here, in that, we have some amazing resources within our communities. What we have to do in order to be able to really truly respond to people's needs is make sure that we are partnered with the people and with the places that those we serve will most likely go to. One of the things that through COVID, as an example, when the conversation of who is best to engage with community members to encourage vaccination. Who is best? Who is best is there. There's a short list. If a patient has a good relationship with their provider, a trusting relationship with their provider, then their provider may be best. But more than likely, it's a community-based organization that resides within the community in which people live that have the best opportunity. Does that mean that a community provider who perhaps creates an outreach space where people can come and be during the day, that they should be doing vaccinations? No, but it means that we should be partnering with that community provider to set up our practices in those spaces. Because those are the people who speak the language of the community. Those are the individuals who more than likely have figured out some way, shape, or form to make sure that those paperwork and documents have been translated. And so that's how we impact change. I think, of course, again, people need resources, and resources continue to be a huge conversation in our nation as far as where our priorities are and how we distribute our funds. But what I want to say is that, we have to continue to move forward and to insist on these opportunities in which we can impact change collectively. And I think that's how we make that difference.
Okay, I don't see any more questions in the chat box, so I'm assuming that everyone has taken home the points as you discuss them. So I would like to thank you for being our Deputy Commissioner and serving the people of the state of New York. I'd like to also thank the Loretta Pines from the Executive Director of the NYACP, the New York chapter of the American College of Physicians. I also like to thank all the members of the DEI task force who actually came up with this concept of this webinar. And to all of you who have spent your time this evening with us, digesting this topic. It's a very, very important topic. What I think I understand from this topic is that this public health law, which is basically seen as a public health crisis, is for all of us, both the providers, the patients, the government. Everyone is actually involved in trying to make this work in any way possible. So that's what I take from the lecture. The government will do their part, we will do our part, the patients will do their part, and hopefully we can move the needle forward. To that end, thank you very much, and then have a good day.